Anyway, so hopefully you can hear me now. I'm going to be speaking today about inflammation and heart disease and C-reactive protein, as was described earlier. And because you can't see me, I thought I would all right, now my slides aren't moving. Here we go. Okay. All right. So because you can't see me, I thought I would give you an idea of what I used to look like. This is my medical school yearbook graduation photograph. And this is more like what I look like now. So this was the first week of April when I volunteered in the Valley Hospital COVID unit. And we were kind of in the midst of everything. And they needed volunteers to help care for the critically ill. So it's a reminder that we all need to care for each other and wearing our masks and socially distancing and washing our hands and all of the usual things. So I know you just heard, so I trained in cardiology, the medical care of heart disease in New York City, and I evaluate and treat patients with known or suspected heart disease of various types in both the hospital and in my office. I have been in a cardiology group practice in Westwood, New Jersey since 1995. And have been a member of the Valley Hospital staff since then, and I joined the Valley Medical Group in 2016. So today we are going to do several things. We are going to review the definition of inflammation. We are going to differentiate between acute and chronic inflammation and their causes. We will discuss the most common current laboratory measure of inflammation, which is high sensitivity C-reactive protein. We will define atherosclerotic cardiovascular disease, and those abbreviations will appear on my slides going forward. And we will explore the association between inflammation and atherosclerotic cardiovascular disease. So, additionally, we will outline the traditional methods of assessing an asymptomatic person's risk of developing atherosclerotic cardiovascular disease, including so-called risk calculators, and we will define them. So, asymptomatic person. We will discuss the incorporation of high sensitivity C-reactive protein and other quote unquote risk enhancers into atherosclerotic cardiovascular disease risk stratification. We will define and differentiate between so-called primary and secondary prevention of atherosclerotic cardiovascular disease, and we will consider treatments and behaviors that can lower high sensitivity C-reactive protein and cardiac risk. So we will begin with the definition of inflammation. According to Encyclopedia Britannica, inflammation is a response triggered by damage to living tissues. The inflammatory response is a defense mechanism that protects organisms from infection or injury. It localizes and eliminates the injurious agent and removes damaged tissue components so that the body can heal. The inflammatory response includes changes in blood flow, an increase in permeability or leakiness of blood vessels, and the migration of fluids, proteins, and white blood cells. So, inflammation is divided into acute and chronic. It's so-called acute inflammation if it lasts for several days, or chronic inflammation if it lasts for a longer period of time. Acute inflammation is often beneficial in terms of the body's defenses and is generally considered a healthy response, which serves to protect and repair the body from something damaging. Factors that can stimulate acute inflammation include microorganisms, for example, viruses or bacteria, chemicals such as acid or alkali, inappropriate immunological responses such as allergies, trauma, and tissue death, as with burns, frostbite, or gangrene. Typical external signs of acute inflammation include redness, heat, swelling, and pain. Examples include redness of the skin after a burn, localized warmth and swelling after stubbing your toe, and pain from a sore throat while fighting off a virus. Acute inflammation typically dissipates when the inflammatory response has done its job. Following acute inflammation, a number of outcomes are possible, including healing and repair, which is the desirable one, suppuration, which is the medical term for the formation of pus, and chronic inflammation. Chronic inflammation, lasting more than several days, can occur if the agent causing acute inflammation cannot be eliminated, if there is some interference with the healing process, or if there are repeated episodes of acute inflammation. In some cases, however, chronic inflammation is not a sequel to acute inflammation, but an independent response. Causes of chronic inflammation include prolonged infection, for example, with difficult to eradicate organisms such as tuberculosis, or foreign substances, such as a splinter embedded in the skin, which remains in the body as a chronic irritant. This type of chronic inflammation typically follows acute inflammation. Another trigger of chronic inflammation is an allergic or hypersensitivity reaction in which an environmental agent such as pollen, which normally poses no threat, stimulates the inflammatory response inappropriately through activation of the immune system, which can lead to chronic inflammation if long-term exposure to the offending agent exists. An autoimmune state is another cause of chronic inflammation, which occurs when a normal component of the body sensitizes and activates the immune system. Like an allergy, the inflammatory defense mechanism is inappropriately activated. An example of this type of condition is scleroderma. This form of chronic inflammation does not follow acute inflammation. Next, we'll move to how we measure inflammation and begin with biomarkers, which are defined as measurable substances in the body whose presence is indicative of some phenomenon such as cancer, infection, or environmental exposure. Inflammatory biomarkers include erythrocyte sedimentation rate, or ESR, procalcitonin, PCT, and C-reactive protein, CRP. The most commonly used inflammatory biomarker is C-reactive protein, which is measured with a blood test. C-reactive protein is a, quote, non-specific biomarker, meaning it does not differentiate between acute and chronic inflammation, nor does it determine the source of the inflammation. High sensitivity C-reactive protein is the most commonly used form of the test and has been extensively studied as it relates to heart disease. So high sensitivity C-reactive protein is the one we're going to be speaking about from here going forward. It has different ranges and measurements involved. The high sensitivity C-reactive protein test measures a protein produced in the liver, which indicates how much inflammation is present in the body. It is an acute phase protein, meaning that it rises in response to inflammation and can fluctuate in an individual over time. Many of the body's proteins pretty much stay steady over time. This particular one can go up and down depending on what's happening to the person. Next, we will shift to some anatomical definitions. So an artery is a type of blood vessel that carries blood away from the heart to deliver blood to organs. So there are arteries and veins. Artery away is how you remember that. Artery takes blood away from the heart. Arteries have three layers: the intima, which contacts the blood, the media, which is a muscular central layer, and the adventitia, which is the outer layer. Beginning in the first decade of life, changes occur in the artery wall between the intima and the media, which can eventually lead to disease in the vessel. Next, we're going to talk about atherosclerosis. So the word atherosclerosis, athero, blood vessel, sclerosis, hard. It's a hardening of the arteries, which is a typical phrase that's been used for many years. Atherosclerosis is the medical term, and it's defined as a deposition of cholesterol, calcium, and other substances in the artery wall between the intima and the media, which is called plaque. Chronic inflammation is instrumental in plaque formation. A plaque may be present and not cause any symptoms at all, and the presence of inflammation can destabilize a pre-existing plaque, which can lead to vascular complications, such as a myocardial infarction, which is the medical term for what's usually called a heart attack. So atherosclerotic cardiovascular disease, abbreviated here, refers to the presence of plaque in the arteries of the body. It is the most common cause of death in the United States of America in women and men, and it is subdivided into 4 major areas depending on the location of the plaque. So there's coronary heart disease, heart artery plaque, cerebrovascular disease, brain artery plaque, peripheral arterial disease, limb artery plaque, and aortic atherosclerotic disease, which is plaque in the biggest artery in the body, which is the aorta. So coronary heart disease may manifest as a myocardial infarction, which is, again, the medical term for a heart attack, angina pectoris, which is chest discomfort resulting from poor blood flow to the heart, typically through blocked heart arteries, congestive heart failure arising from damage to the heart muscle related to poor blood flow, or sudden cardiac death. So those are examples of coronary heart disease. Cerebrovascular disease can present as a stroke or transient ischemic attack, or TIA. Peripheral arterial disease symptoms occur when poor blood flow to the extremities causes pain with exertion or at rest, and or gangrene. Aortic atherosclerotic disease may be associated with enlargement, which is called an aneurysm, and or rupture. Now we will shift to a discussion of risk factors. So risk factors are characteristics, conditions, or behaviors that increase the likelihood of developing a disease. Risk factors often coexist and interact with one another. Risk factors can be modifiable, meaning that an individual can alter their risk depending on their actions, and non-modifiable, meaning that a person has no control over those risks. So risk factors fall into several categories, including behavioral, physiological, demographic, environmental, and genetic, and we're going to define those next. Behavioral risk factors relate to actions that an individual has chosen to take. They are modifiable because they can be changed. An example is smoking or vaping. Physiological risk factors are related to an individual's biology. They may be influenced by a combination of genetics and lifestyle and are therefore modifiable to a degree. An example is being overweight. Demographic risk factors relate to the overall population. An example is age, which is not modifiable. Environmental risk factors cover a wide range. An example is air pollution, which is potentially modifiable. Genetic risk factors are based on an inborn genetic makeup, which is non-modifiable, which can predispose a person to certain diseases. There can also be environmental interactions with genetics, which are potentially modifiable, such as with asthma. So now we're going to speak about atherosclerotic cardiovascular disease risk factors. And traditional risk factors, which are items as listed below, which have been studied for decades, can be both modifiable and non-modifiable. So the classic traditional risk factors for atherosclerotic cardiovascular disease include age, smoking, cholesterol levels, total cholesterol levels, high blood pressure, and the use of antihypertensives. So a person who has high blood pressure, which is controlled on medication, still falls under the category of this particular cardiac risk factor. Obesity, sedentary lifestyle, family history of premature atherosclerotic cardiovascular disease, which is defined as before age 65 in women and 55 in men, and diabetes. The presence of traditional risk factors predicts a higher risk of developing atherosclerotic cardiovascular disease. Risk assessment is the process of evaluating an individual's likelihood of developing a disease using statistics. Risk assessment tools, such as the Atherosclerotic Cardiovascular Disease Risk Calculator, published by the American College of Cardiology, incorporate traditional risk factor data of thousands of people over time and are used to help predict the likelihood that a specific individual will develop atherosclerotic cardiovascular disease, so we can target interventions. When a risk calculation is performed using the ACC tool, traditional atherosclerotic cardiovascular disease risk factors for an individual are used to obtain a numerical prediction by statistical methods. The number we obtain estimates the individual's likelihood of developing ASCVD over the subsequent 10 years, which is called risk stratification. There are 3 risk stratification categories: low risk, intermediate risk, and high risk, which estimate a person's likelihood of developing ASCVD based on decades of statistics from thousands of individuals. So how do we use risk scores? Patients who have a low risk score are advised to follow a healthy lifestyle in terms of diet, exercise, and stress management. And with the ACC calculator, that's a less than 5% 10-year risk. Patients with a high risk score additionally warrant, in addition to the lifestyle measures noted above, aggressive treatment to lower their risk, often with medications to lower their cholesterol, despite the absence of symptoms. So even if someone has no symptoms, if their risk score calculation is in the high risk range, we would consider giving them medications to lower their cholesterol and reduce their risk because of their statistic susceptibility. Patients with an intermediate risk score, oh, and by the way, the high risk score is greater than 20. So low risk is less than 5%, high risk is greater than 20%, and intermediate is typically between 5 and 20%, 10-year estimated risk. So people with an intermediate risk score often require additional information to help decide how to reduce their risk of developing atherosclerotic cardiovascular disease. So next we will discuss risk enhancing factors which help with this process. They're also called risk enhancers. And these are conditions that confer an increased risk of developing atherosclerotic cardiovascular disease in addition to the traditional risk factors used in risk estimate calculations that we talked about before. Risk enhancers are useful in people with intermediate risk scores obtained from a risk calculation. So first you do a risk calculation, and now if you're in that intermediate group, we move on to the next analysis. So risk enhancing factors are listed here. An elevated high sensitivity CRP level is considered a risk enhancing factor and therefore can be incorporated into decision making regarding preventive interventions in conjunction with intermediate cardiovascular risk calculations. Other risk enhancers, and this is important, these are non-traditional risk factors but have been shown over decades of research to increase a person's risk of developing atherosclerotic cardiovascular disease, include preeclampsia, early menopause, which is defined as before age 40, rheumatologic diseases such as rheumatoid arthritis, HIV infection, South Asian ancestry, chronic kidney disease, triglycerides greater than 175 milligrams per deciliter, and elevated lipoproteins, which are specialized cholesterol measurements. So now we will come to the interplay between inflammation and atherosclerotic cardiovascular disease. Inflammation plays a role in the development and destabilization or rupture of atherosclerotic plaque in blood vessels. Inflammation can also promote vascular remodeling, which can lead to stiffness in arteries and can be associated with high blood pressure and the development of congestive heart failure. Chronic inflammation has also been linked to insulin resistance and type 2 diabetes, which are major risk factors for atherosclerotic cardiovascular disease. The most extensively studied biomarker of inflammation in atherosclerotic cardiovascular disease is high sensitivity CRP. Data from numerous studies have shown a significant association between the elevated levels of hsCRP and the presence of ASCVD and cardiovascular events. Heart disease risk is estimated, and that's in red for a reason, using high sensitivity CRP as follows, and we'll talk about this further. Levels of less than 1 milligram per liter are considered optimal. Levels between 1 and 3 milligrams per liter indicate intermediate risk. Levels above 3 milligrams per liter suggest high risk. And remember, we talked about the fact that this is what they call an acute phase protein, and the presence of inflammation of various sorts can affect it. And it's important to realize that values above 10 milligrams per liter may signal an infection or other cause of inflammation, which is potentially reversible. So typically the test is repeated 2 weeks later, and the lower value is used to assess cardiac risk. As we have discussed, inflammation contributes to the development and destabilization of atherosclerotic cardiovascular disease. High sensitivity CRP measurements are a way to measure the presence and degree of inflammation in an individual. High sensitivity CRP is considered most helpful in people who have those intermediate risk calculations using traditional cardiac risk factors as determined by risk assessment tools. Now we're going to shift a little bit with some more definitions. So primary prevention of atherosclerotic cardiovascular disease is defined as recommended measures taken to prevent the disease from ever developing. Primary prevention, prevent the disease before it occurs. We assess an individual's risk of developing disease based on their background and medical history when they have no symptoms or known heart disease, using the risk calculator and incorporating risk enhancers, including high sensitivity CRP when appropriate. These results help determine who should receive treatment to reduce their further risk. The risk calculators are only used for primary prevention in individuals with no known atherosclerotic cardiovascular disease, and that's important. Secondary prevention is treatment meant to prevent subsequent events in people who have established atherosclerotic cardiovascular disease. For example, preventing a second heart attack in a person who has already suffered one. The risk calculators are not used in this situation. This person already has the disease, and you have to do everything you can to reduce the risk in the future. So high-level intervention is already recommended. High sensitivity CRP for secondary prevention has predictive value in terms of subsequent cardiac events, as well as the development of congestive heart failure and diabetes, and is a research tool. It is not routinely followed in patients who have established atherosclerotic cardiovascular disease. So next we move to the concept of screening. There are certain screening tests which are well established, mammograms, colonoscopies, but the use of high sensitivity CRP to screen the general population is controversial. Many people will say, I've never had this test done. It's not done in everyone. It's only done in specific situations, which we're reviewing today. Traditional risk factors remain the mainstay of screening for atherosclerotic cardiovascular disease. And the current recommendation is to consider high sensitivity CRP testing in patients with intermediate risk based on risk calculation as described previously. And it's important that normal ranges of high sensitivity CRP have not been definitively established. So we talked about those ranges earlier, less than 1, 1 to 3, greater than 3. Those are ranges that are associated with potential for increased or reduced risk. How does high sensitivity CRP influence treatment? So the values may assist in risk stratification in those intermediate risk patients we keep talking about when considering medical therapy for primary prevention. High sensitivity CRP values may also serve as tangible evidence to help people adhere to healthy lifestyle changes in terms of diet, exercise, and stress management. Sometimes when people hear that there's an abnormality, it makes them more likely to follow instructions. A number of drugs prescribed for primary and secondary prevention of atherosclerotic cardiovascular disease have been shown to reduce high sensitivity CRP levels. It is therefore possible that reduced inflammation contributes to the beneficial effects of these treatments, although cause and effect have not been proven. Some statin medications have been shown in medical studies to lower high sensitivity CRP, and statins are commonly used medications for cholesterol lowering. The ones that have been proven to lower high sensitivity CRP are listed here. Atorvastatin, which is Lipitor, simvastatin, which is Zocor, lovastatin, which is Mevacor, and pravastatin, which is Pravachol. Ezetimibe, which is Zetia, and which is a non-statin that lowers cholesterol by a different mechanism, also lowers high-sensitivity CRP levels. Aspirin reduces high-sensitivity CRP and is a known anti-inflammatory, but it's currently used mainly in patients with established atherosclerotic cardiovascular disease for secondary prevention. Recent large trials have been disappointing regarding the use of aspirin for primary prevention, and for most people, it's no longer recommended. So, stress, depression, diet, and high-sensitivity CRP. Studies have shown an association between elevated levels of high-sensitivity CRP and increased risk of psychological stress and clinical depression. Further research is underway regarding this intriguing topic. A diet rich in fiber and vegetables has been shown to lower high-sensitivity CRP. Additional study is also in progress, but I do urge everyone to eat their vegetables. Plant-based diets are very healthy for us. So, takeaway points for us. Atherosclerotic cardiovascular disease is the #1 cause of death in women and men in the United States of America. The presence of inflammation contributes to the development of atherosclerotic cardiovascular disease. The most extensively studied biomarker of inflammation in atherosclerotic cardiovascular disease is high-sensitivity C-reactive protein. Numerous studies have shown an association between elevated high-sensitivity C-reactive protein and the presence of atherosclerotic cardiovascular disease and adverse events in patients. The numerical value that constitutes an elevated high-sensitivity CRP is not clearly defined, but ranges have been used to help stratify risk when traditional risk factor calculations are in the intermediate range. And finally, the use of high-sensitivity CRP to screen the general population is controversial. So now, if there are any questions, I'm not sure how we do this.
Okay, thank you so much, Dr. Murphy. This is excellent, and I would really, encourage people to, on the right side of your screen, to write in a couple of questions if you have any. This is really comprehensive and was an excellent program. Thank you so much. So I'm just waiting a moment for maybe a couple of questions.
Bottle home I can give you. Otherwise,
Hello?
I used to get.
Okay, can you speak up, please? Oh, I thought I heard someone speaking. Dr. Murphy, I thought it was interesting what you said about the stress and what's going on with all of this. We have found definitely at Valley in the ER and in our hospital in general, the impact of stress. And of course, this year, things have been extra stressful. I wonder if that's impacted your practice at all?
Yes, I've always been a big proponent of healthy lifestyle. And so I really spend time with people talking about diet, exercise, and stress management in detail, because just saying, oh, you have to do those things without some clear-cut advice or recommendations is important. So with diet, I do talk about a plant-based diet. Eating your vegetables, which everyone's been hearing about since childhood, has really been shown to promote good health. Regular exercise, which the current recommendations, if people can do it, are 150 minutes per week of cardiovascular exercise, and walking counts. It averages out to about a half an hour a day. And the more physically active people are, the more it helps with the third issue, which is stress. And so, yes, everybody's got stress, and people really do respond very differently to it. I think it's important to recognize that you are under stress and to find what methods work for you to reduce that. There's been lots of research done on breathing techniques to help stress, and I always say you always have your breathing with you. And so I instruct people the concept of pranayama breathing, for example, is a form of yoga breathing that breaks down to breathing in and out through the nose in a rhythmic fashion. So breathing in slowly to the count of 6, holding the breath at the top, and then out slowly through the nose to the count of 7. is one way to help to reduce. It's been shown to reduce pulse and blood pressure, and it's something that you always have with you to help you to reduce your stress, sort of helping to distract from whatever it is that's got you kind of up in arms. So yes, I have certainly seen a description of increased stress in my patients in this time of great difficulty. I've also seen an incredible outpouring of care and affection for each other and for us, the healthcare workers, from my patients as well.
Oh, that's excellent. Thank you so much. I do have a couple other questions the audience have. The first question is the total of cholesterol levels more important than taking into account the individual levels of LDL and HDL? And
Excellent.
to confirm,
Okay.
Good. And just the second part of the question, is the use of daily aspirin no longer recommended? That's what they heard you say. That's all.
Yes, Yeah, so I'll start with the aspirin thing. Yes, daily aspirin is an individualized decision with the patient and their doctor, but routine daily aspirin use is no longer recommended for most people because they did studies in tens of thousands of people looking at this primary prevention, potential primary prevention tool, and in fact, it was shown not to be effective. Aspirin increases bleeding and bruising risk. It can worsen gastroesophageal reflux disease or upper gastrointestinal bleeding. And so the benefit is thought not to outweigh the risk for primary prevention. Anyone who's had any kind of a vascular issue, be it a stroke or a heart attack or peripheral arterial disease, typically will be taking an aspirin, but for primary prevention, we are no longer recommending it routinely. Regarding cholesterol, so the total cholesterol is one of the traditional risk factors. So that goes into the risk calculation. But the breakdown, the HDL, the LDL, and the triglycerides are also very useful tools in helping to decide whether a person should be aggressively treated. So in terms of risk enhancers, that high triglyceride above 175 is a risk enhancer. The lipoprotein levels, which are the breakdown of the different types of cholesterol, are used. So that's part of the sort of global evaluation of a person to help decide if they need cholesterol-lowering medicine who's asymptomatic and doesn't have proven disease. So you do the risk calculation, which there's an app on my phone that I plug all the information in, but then you take these other factors into account, including those, to help to decide what to do. There are other tests such as a coronary calcium score, which is a CAT scan looking for calcium deposits in the heart arteries. Remember, calcium is one of the components of a plaque. And if a person is in the intermediate range but has some calcium plaque in their coronary arteries, it definitely pushes you more in the direction of aggressively treating to lower their cholesterol, in addition to those lifestyle measures we talked about.
Okay, thank you so much. I appreciate that. Somebody else had asked, I wanted to know if you have chronic inflammation in, for instance, your knee, can that affect your heart, inflammation in other parts of the body?
Yes, that's an excellent question. So the concept of inflammation is one of many factors that contribute to the development of atherosclerotic cardiovascular disease. And, you know, the degree of inflammation from chronic knee pain or knee problem is probably less than, for example, if someone has rheumatoid arthritis, which is an autoimmune chronic inflammatory disease, which is known to have high levels of inflammation for many years. So the classic osteoarthritis of the knee theoretically could contribute because of the presence of inflammation, but is unlikely to be a major contributor to the development of atherosclerotic cardiovascular disease.
Okay, thank you. So somebody asked a little bit about two-part question. Why is the C-reactive protein test controversial? And should I routinely request my cardiologist give me one of these tests? Yes.
So, in terms of controversy, the controversy is more, when you hear a talk or you learn about this, you think, oh, do I need it? Which is exactly what all of you are asking. So the use of the test is in people to help to decide if you're in that intermediate range. So everybody should have their risk calculated based on their age and gender and blood pressure and total cholesterol levels and whether or not they're on blood pressure medicine or they smoke the usual ones. And when you do that calculation, if you're at less than 5% level, you can stop there unless you have a lot of those risk enhancing issues. Then you could consider going further. It's so individualized. If your risk calculation comes up above 20%, then a high sensitivity C-reactive protein test isn't going to help your management because you already know you need to do everything you can to reduce your risk with lifestyle and potentially medications. It's in that middle range, which is a pretty big range from 5 to 20%, that it's more helpful. And so you individualize, and that's one of the tools that can be used to help push people, not push, but encourage people to take cholesterol lowering medications. If you have a CRP greater than 3 and and your risk is 12%, then it's most likely recommended to take medications to lower the cholesterol, just because, again, atherosclerotic cardiovascular disease is the #1 cause of death in women and men in this country. And yes, we all have to go from something someday, but we would like for that to be as far in the future as possible, and everything in our power that we can do to reduce that risk is important.
That's great. Thank you. Another question is, if your only risk factor is a very strong family history, yet you have had a cardiac calcium scoring of 0, is it still important to consider this this process and test?
That's an excellent, excellent question, because the genetic risk is real, and your genetic risk is only one component of the assessment that a person will have. So your age, your gender, whether you're cigarette smoking, all of those traditional risk factors need to be taken into account. Then the coronary calcium score of 0 is a great piece of news, because a 0 score is very helpful in predicting future events, but there's no such thing as perfect. And so if you have a positive family history and you have a negative calcium score, but you're type 2 diabetic, for example, then even if you're healthy, well, and fit and have type 2 diabetes, it's still going to be recommended if you're over 40 that you be treated with cholesterol lowering medications based on current guidelines. So it's definitely important to individualize the treatment. There are some people who never want to take medications for anything, and there are other people on the other end of the spectrum who would like a prescription, who feel more secure in having a prescription. So that's why each individual has to have that discussion with their doctor to help. There's no really black and white recommendation for a lot of these things.
Okay, thank you. Somebody else speaks about having a history of a recent heart attack, receiving 2 stents, and then doing very well and adhering to a low sodium, low fat diet, almost salt free. But should that person still be tested for C-reactive protein in the future?
Okay, another excellent question. So this is where we get the division between primary prevention and secondary prevention. So high sensitivity CRP is used for primary prevention risk assessment in someone who doesn't have established disease. If you've had coronary artery disease with stents, you already have documented atherosclerotic cardiovascular disease. So I applaud all of the healthy lifestyle measures, but the high sensitivity C-reactive protein, as of now anyway, is not used. There was one slide where we talked about that perhaps if your level is high, it could increase your risk of developing complications down the line. But that the presence of an elevation, other than making you nervous, doesn't change the fact that you need to do all that you can to stay as healthy as you can. And that gets exhausting over time. So people are often very gung-ho at the beginning, but we have to just continue to do our 150 minutes of exercise, try and eat our mostly plants, and manage our stress, in addition to the medications prescribed for the disease.
Yeah, take into a lot of into account. And I do think, like what you're saying, a lot of people are asking about family history and their concerns. So it just sounds like you just have to be extra careful and diligent about these things.
Yes.
Finally, final question is, where can I get the risk calculation? Does that make?
Well, there are apps, believe it or not, that you can do, but you need to, at the American College of Cardiology, atherosclerotic cardiovascular disease Risk Estimator Plus. And so, you know, you can get the app, but you do need certain information. So it asks you your age, your gender, race, systolic blood pressure, which is the top blood pressure number, diastolic blood pressure, which is the bottom blood pressure number, total cholesterol, HDL cholesterol, which is the good cholesterol, LDL, whether you have diabetes, whether you've ever smoked, and if so, how long ago you hopefully quit, whether you're on hypertension treatment, whether you're on a statin, and whether you're on aspirin. This is based on some of the previous data. And then you can get a risk calculation that tells you, and there's even advice in there based on what a person will have. Now, I do not suggest that everybody necessarily go and do that on their own, but going to your doctor with armed with that information, with the cholesterol profile and blood pressure and such, I do them every day for people and help advise them. Maybe I'll order a calcium score, or maybe I'll order an hsCRP or other such things, depending on their background, to help them decide what happens next.
Okay, thank you. Okay, and just one final question.
Sure.
My cardiologist ordered a CRP test from LabCorp. It does not say high sensitivity CRP, just C-reactive protein. Would it automatically be high sensitivity?
So that's an excellent question too. So remember, we went through the evolution of the test. So the original C-reactive protein was pretty much a non-specific marker for inflammation. And the next generation test was this high sensitivity C-reactive protein. And that's the one that is used most in these studies that have looked at inflammation and heart disease. So if you have a regular one, it will not necessarily be upgraded to the high sensitivity. It has to be ordered that way. But if your C-reactive protein is, they do put normal ranges in there. If your C-reactive protein is in the normal range based on that one, then that's good news, but it's not as specifically studied as the high sensitivity one. And so having the high sensitivity one instead, if that hasn't been done, would be reasonable. But I wouldn't get your blood tested specifically for that. The next time you're having a blood test, you can ask for the high sensitivity one.
Okay. Thank you so much. We really appreciate your time, your wonderful presentation, and your patience in answering all these questions so thoroughly.